Hey everyone, thanks for joining me here on the main event. My name is Joe Tillman, and you're watching the main event on the Hair Transplant channel. Really glad to have everyone here. If you don't know who I am or what I'm doing here in front of this microphone, my name is Joe Tillman. I've been in the hair transplant, the surgical industry for 21 years, or 20 years actually. And I've had many hair transplants myself. I started out as a repair patient many years ago. And once I got my first repair surgery, it was so great for me. And I was so happy. I became obsessed with surgical hair restoration and what it can mean when you go to a doctor that has good hands, and got hired by the clinic. And here I am today. I don't work with that same clinic any longer. I work with about 15, I think, individual doctors from around the world that I have on my website, hairtransplantmentor.com. And they are listed as doctors I feel you should consider because I have reviewed them. I've been to many of their clinics using my own clinical experience to review and inspect their clinics, make sure that they're up to snuff, as it were. And yeah, so that's how we're here today. And this is a unique episode where, excuse me, I'm going to be allowing phone calls. I do have a phone number. I didn't have time to put it up in the on the title or as an overlay because I was just setting all this up today and dealing with a sick dog, dealing with contractors for a leak in my roof. It's fun times. But it is 1-833. Hold on, just double check. I forgot. Yeah, 833-563-4247. That is a toll-free number in North America. It's 1-833-563-4247, and you'll be able to call in and ask questions. But the other development is I'm going to have a guest here in just a bit. It is Dr. Aron Nusbaum, Hair Transplant Mentor, accepted Dr. Aron Nusbaum from Miami, Florida. The website is miamihair.com, and I contacted him today just to see if he'd like to be the first guest on basically the inaugural episode of the main event. I've had 4 episodes before, I think. Yeah, 4 episodes before, but they're kind of impromptu, not really scheduled. Just kind of feeling my way through things, doing this solo and setting up phone systems and all that good stuff. But yeah, so he's agreed, and he'll be popping in as soon as he's done with, I think, a consultation. And then he said that while we're doing the discussion, he'll be answering your questions. It won't be just an interview. I'll be asking him some questions as well. But he will be pulled away to check out a patient that's finished up with surgery and take care of that stuff. And then he'll try to come back to us if we're still on air. So in the meantime, I will get to the chat here. Just a second. Let me go. Let's see, where is it? Change. Sorry, I'm just getting a notification here. Got to check this out. I'm running everything myself, so I'm just checking out notifications I'm getting. I need to change my current resolution. Don't know why. Stream status is poor. Okay. Stream settings. I don't know why. Huh. It's looking good on my end. Anyway, yeah, so let's see. Got some questions here already. Joe, would you please clarify Hamilton-Norwood scale number 1 versus juvenile hairline? Same thing. I'll let Dr. Nussbaum answer that as well whenever he calls in, but it's the same thing. A Norwood 1 is a juvenile hairline. I think I was talking about this yesterday. And let's see. World Music and Arts, looking forward to it. Thank you very much. And Nico, can Dr. Nussbaum sell me his hairline and eyebrows? I know, right? It's funny about hair transplant surgeons. A lot of them have either phenomenal hair and would never need a hair transplant, like they're genetically gifted, or they're full-blown Norwoods, where they couldn't get a decent hair transplant if they wanted to because they just don't have enough donor hair and they're just that bald. Nothing against, nothing wrong with that, but that seems to be the mix. There are some really good hair transplant doctors that have had really good hair restoration procedures. There's one, I won't name him, but there's one that is out there. He's had a really good hair transplant. I know who the doctor was, and he and I have talked about his procedure off camera and behind the scenes. but I've never heard, I've heard someone mention that they heard that he had one, but no one's actually critiqued it. No one's ever actually discussed it online. Like, you know, hey, this doctor, you know, what do we think of his procedure or anything like that? So it's interesting how that works out. But yeah, he's definitely got some crazy hair. Milk drinker. I think a lot of people distinguish between Norwood 1 and juvenile hairline or Norwood 0. Maybe, but again, I think I was saying yesterday, anything below a Norwood 2 technically doesn't exist on the hair loss scale because it's not hair loss, right? So, and it was just a construct created by maybe a clinic that, you know, wanted to talk to their patients that are Norwood 2s or Norwood 3s that wanted to have that kind of hairline back, showing that it is something that maybe I don't know. I'm just speculating here. But let me just double check some notes here, make sure he's not trying to call in. No, don't see. Okay, nope, he's still dealing with his business and his clinic, and that's the way it should be. So, right, what we got here? Like I got a lot of things to share, but I'm not quite sure how to share them because, you know, I oops. Turn that off. There we go. Sorry. I deal with a lot of things through the day, through the week when it comes to hair restoration. And sometimes I'm very shocked. Sometimes I'm disappointed. Sometimes I'm mortified by what I see or what I hear or what I read doctors are writing or patients are writing. And it says to me that, you know, what I've been telling people for a long time on The Bald Truth with Spencer Coburn, and he's been saying it as well. This industry, this hair transplant industry, is worse now than it's ever been for patients. It's worse now because patients have lower expectations of what it means to have a good result or what a natural result looks like, and clinics have popped up that help to perpetuate this lack of education. And in many cases, I don't think it's the clinic's fault because they themselves don't know what they're doing. They don't understand the differences between what they're doing and what, say, you know, like Dr. Nusbaum's doing, which, you know, he does fantastic work. And sometimes I struggle, like on the Friday show on The Bald Truth, I want to convey this stuff to you guys, but there's just not enough time to really break these issues down the way that I feel like they should be. And that's my frustration. And I think I mentioned this a little bit yesterday when I was talking about creating videos for you guys where I do everything myself. I shoot, I edit, I produce, I do all the things in my own videos, where it's just frustrating where I can't get as much information I want into one video. And if I did, it would take months, maybe months to edit that one video. And so I try to break them down, but it's just a frustration. And I guess I'm kind of venting on that frustration right now because I was looking at a result today. Someone had posted in between some things I was doing on some platform, and he wanted to know what people thought of his result. And I looked at it, and it actually reminded me of my own result before I had my repair surgery with Dr. Wong 21 years ago. And I saw people on there saying, not only does it look natural, they were saying, in response to people, some people were saying it did look unnatural, so credit to them. But the ones that were saying it looked natural would also reply to the ones saying it was unnatural, saying, it's better to have this than to be bald. No. It's all subjective. It's all one's opinion. But coming from someone that has had that hairline in my early 20s, my mid-20s, late 20s, and in up to the age of 31 or 32, I forgot. 32, yeah. It is not better to have that than to be bald. Full stop. I remember thinking to myself that I would have loved to have shaved all of it off, and I would have. And I didn't even care about the 2 strip scars I had stacked in the occipital scalp. I didn't care about that. I cared about how it would look 2 days after I shaved it, or even 1 day. Like, I didn't know what it would look like, but I could see those thick ant legs on growth hormone grafts sticking out, and I could see how pitted they were. So I knew, and also the ridging that came from it. So I knew that, or I thought that if I had shaved my head, the pits and the ridging and then the little tree trunk grafts would be visible, immediately upon shaving, and then the grafts coming out over the next day or two as they started to regrow. That's why I never shaved my head. I would have loved to have shaved my head if the result did not scar my scalp, if I didn't have all that pitting and ridging. So I don't know. Like, I'm kind of at a loss of what to do, because I'm just one person, and I am noticing there are more people that are recognizing some bad work that's out there. And when I say some people, I'm talking about just average anonymous persons that are posting on different platforms. It is being called out a little bit more, but it's not nearly enough. And it's just frustrating. I'm kind of venting. So thank you for indulging me that. So let's get on to some more comments here. Sergey, I think Dr. McGrath had several hair transplants. Yeah, I'm pretty sure he has. I don't know the details, but I'm pretty sure he has. Milk Drinker, Dr. Seti says that a juvenile male hairline is different from a female. Yeah, they are different from a female hairline. They are different, but they both have typically blunted corners. In fact, I think Dr. Erica Bonsall did a video. Yeah, she did a really good video on female hairlines that talks about the different kinds of female hairlines. It's a very good video. I do recommend people check that out. But when I talk about that stuff, it's just in general. It's similar, but there are a lot of female hairlines that do mimic juvenile male hairlines. There's no single type of hairline that all women have. I don't think that would be the interpretation of what I said, but if it is, then that's the correction. John Doe, please remember to thumbs up. I appreciate that. Thank you. Milk Drinker, did the ant legs look okay if you wore a fringe bangs? That's another problem with the result that I was just talking about. I couldn't do it. And this was suggested to this guy. You can hide those bad grafts by just kind of wearing a Caesar cut. No, you can't. Because two things in my situation, and this guy would have the same problem. Number one is the vertical placement of those grafts. Hairline grafts and frontal hairline grafts are supposed to be angled forward, give or take several degrees, about 45 degrees to the plane of the scalp, so that they kind of lay out like this. And he can't do that because they were straight up and even slightly backward. But there's also the issue of the lack of density. Like, there's a big space in between those grafts. So when you try to brush it forward, even if it was angled properly, it wouldn't cover. It would be clumpy, and you'd have these. It would look like doll hair if you brush it forward. You'd have these strands that kind of separate from each other. It's not a good look. Like, you can't do anything with it. The only thing he'll legitimately be able to do with it is maybe comb it to the side or either side, or even back. And he's going to need another surgery to camouflage it, or even to remove those frontal grafts if it's too low. I wasn't able to see how low the hairline was. So let's see, Nico, I've been noticing female hair loss more than normally walking down the street here. It's because you're more aware of it. I wouldn't say that there's a bigger issue with it in general, but you're more aware of it, and so you notice it. It's like buying a car for the first time that's a certain color. You start noticing all kinds of cars on the road the same color, and you didn't notice them before. That's the way that works. Sam Ellie, this is perfect timing for the show. 11:18 p.m. here in London. Awesome. Sergey says, Dr. Anderson said his safe upper limit for density of implantation is 30 to ensure survival. Yeah, and a lot of doctors feel that region of density is where they should be as well, and some much higher, and some even lower than that, which is interesting. Still to this day, would be interesting to hear Dr. Nussbaum's upper limit. Yeah, I agree, and we might be able to do that here pretty soon. Looks like he's calling in, and I'm going to give him another minute to set up. Looks like he's getting his gear going on. But again, thank you everyone for tuning in. I'm pretty excited by this. It's the first solo effort for the main event, and Dr. Nussbaum's the inaugural guest. I'm really happy to have him on board. And before we get him on board, show your appreciation, folks. I do this for free. Hit that like button for me. In fact, I won't bring him on until we get 15 likes. I got 13. I need another 2. So I'm watching. We got 14. All right. Doc, I don't know if you'll be able to come on. We'll see. All right. And okay, there we go. Let's see here. So got that. And Dr. Aron Nusbaum.
Hi, Joe. How are you doing?
Good, sir. How are you?
Doing well. Pleasure
Thanks for joining us
here as the inaugural guest to this great show we have going on.
Yeah, absolutely, man. How's your day?
Normal day. We did 2 procedures today and just getting finished up here, and happy to spend some time with you and all the listeners.
Awesome. I don't have the side-by-side screen set up, so maybe during the broadcast we'll be able to get that set up. But I need to ask everyone in the chat room, can you hear? I know you can see Dr. Nussbaum. Can you hear Dr. Nussbaum with his last comments? And I got to give it a few seconds for the delay. Yeah, okay, you can hear. All right. Not sure what that sound was, but okay. That was kind of weird. But yeah, I've been answering some questions, some general questions, Doc, in the chat room. No one's called in yet. If anyone does want to call and ask me some questions or ask Dr. Nussbaum some questions, they can call toll-free 1-833-563-4247. That is toll-free in North America. If you're in Europe, UK, or Europe itself, I don't see why you couldn't use Skype or some other free app to call, so you don't have to worry about international charges. But yeah, you can give that a shot. So let's see, we got some questions here in the chat room. Does Dr. Nussbaum do a lot of repair procedures, and if he's had any recent memorable ones that are difficult? That's from Tyler.
So, Tyler, we do, I would say probably, unfortunately, probably about 15 to 20% of our cases are repair work. This really has a broad range of cases, anywhere from, we had a patient today that actually, we didn't do a surgery today, we saw him for a follow-up, where we actually did some excision of previous punch removals, dissected the grafts down, and then reimplanted them, or plug removals is what I would say. And, that's something that we don't see that often, but that was quite a memorable one, as I would say, in my recent memory that I've done. Also, what I'm seeing a lot of mostly is incorrect positioning of the hairline. And this is nothing new to you guys listening to Joe and Spencer all the time, but incorrect positioning of the hairline. Mostly what bothers me the most is incorrectly done temporal recessions and temporal points, either with the angles being sort of blunting the corner. And what really is kind of a pet peeve of mine is in the temporal area, these grafts have to be placed and have to lay flat. And what I see all the time are sort of these, I call them antennas, where they're just sticking up outward, and mostly with large hair grafts. Sometimes we can get away with just camouflaging them with a bunch of singles in the area, but oftentimes we always tell patients, it's never going to be as good as if you let us do graft removals. And graft removals can be tedious to do. Everybody always wants to know, is the follicle still viable after the removal? I think about 50% of them, 50 to 70% of them can be saved. But because the architecture of the follicle has sort of been distorted after it's been planted and sort of scarred down, it can make the extraction process a little bit more difficult, and you cannot always reuse these grafts. So my suggestion when we're doing repair work always is to if you trust the surgeon, allow them to do the graft removals, even though everybody gets paranoid about taking grafts out that they've already paid for, already had in. At the end of the day, the result is going to be far more superior than simply just having somebody soften your hairline or fill in some singles.
Right. Okay. So, see, I just, oh, I got to get the wrong. There we go. Sorry, I was trying to get that side by side working, then my audio cut out. So that's interesting to know. My question that popped up, and I generally don't know the answer to this about how you do things. When you're doing, say, some hairline graft extractions, and I don't know what your limit, like where you would call it to be too much in one surgery or what, but if you're taking out grafts from a hairline and you're assuming you're redistributing them if they're viable, how do you deal with that hairline after the fact? In other words, aside from just removing grafts to raise the hairline to a more appropriate level, are you ever in a situation where you need to place new grafts into that same area because maybe they were multis or just unsightly? Like how do you deal with extraction and then reimplantation in the same area? Oops.
I don't find that simply removing grafts is ever enough. I can think of a few cases where there's been a couple stragglers where I've had to pull 10, 20, 30 grafts out. But generally, when we're speaking sort of about these repair cases or these malpositioned or incorrectly positioned hairlines, we do need to first do sort of a graft removal procedure. We tell the patients we can try and redistribute them somewhere further back in the recessions or in the crown or somewhere else that they're losing hair. And then sometimes we will often, not always, but if a lot of the grafts were taken close together, you may need to come back or they were placed close together, you may need to come back and do a second round of extractions. Or sometimes if you have to take two sort of together and they create sort of a figure eight, we will actually put a very fine, like a 6-0 or 7-0 suture for 3 days just to keep the hole closed. Okay. What was surprised about is that the healing is remarkable. If you're using a small, regular 0.9 millimeter, 0.8 millimeter punch, you may need to go up to a 1 if it's a larger hair graft, but the healing is remarkable. Really, a week later, you cannot see anything. The interval that I will tell patients that they have to wait before we can do definitive further grafting of the hairline is 6 to 8 weeks after the repair. So that's typically what we would do. Sessions of removals, depending on how many grafts need to be taken out. Sometimes you have to suture them, sometimes you don't. If you do, the sutures will come out at like 3 days later. And then there's an interval usually of 6 to 8 weeks because you want to make sure that the skin is completely healed before we're going to go reintroducing new recipient sites into that area.
Right. Okay. All right. That's comprehensive. Thank you. That's good. I got another call here. Let's see. Hold on a second. Okay, you're on the main event with Joe Tillman and our guest, Dr. Aron Nusbaum. What's your name and where are you calling from? I think I know who it is. No, I don't. I thought I thought it was Morty. Oh, what? You're calling from Chile? What? Oh, wow. And you're the first caller. Now I got to ask you, were you asked to call today? Sorry, I think I'm having a. Sorry, I'm glad you called, but I'm getting a note that we can't hear you on the show.
Yeah, I can't hear him, Joe.
Oh, you can't hear him either. Okay.
No.
No. That's good. You and I can talk, but apparently the audience can't hear you, and neither can Dr. Nussbaum. So let me see if I can get this going here. Let's see. So what you guys couldn't hear is that this is, and Dr. Nussbaum, you couldn't hear this. This is your patient from Chile that had an FUT with you.
Wonderful.
Thank you. That's good to hear. Let's see. I just need to. I was going to say you guys can talk it out while I'm working on the problem, but you can't hear each other.
What a small world.
Yeah. Well, yeah. And he said that
I didn't tell him to call. I promise.
No, he confirmed that. That's funny. I'm not sure. Let's see if I can do this. Hold on, everyone. Thanks for your patience. There we go. All right. Caller, give me say a few words.
Hello?
Yeah.
Can you hear me?
Doc, can you hear him?
I can. How are you?
Okay, there we go. Got it.
Oh, hello, doctor.
How are you? Who is this? I have a guess.
This is Cristobal from
I
Chile.
knew who it was.
Your patient, 7 months ago.
Well, how many patients
I know
from
you do a
Chile
lot
do
of
you have?
A
So
good
easy to-
amount, actually. You'd be surprised.
Really? Okay.
Yes.
Wow.
I was telling Joe that I wanted to thank you both because the only reason why I went from Chile to Miami and flight 12 hours is because of Joe. I follow him from a long time ago. So I'm super happy with my results, and thanks to you and thanks to you, Joe. Is there any space here to ask a hair loss related question, or this is not the place?
No, of course. That's why we got this set up. And I just got to say, everyone watching this was not set up. Like I didn't.
No, yeah, I swear of God.
This was.
I was just on YouTube and I saw you both, and I wanted to join. Okay, so my hair loss related question is, what are your thoughts regarding topical dutasteride?
Okay.
Do you recommend it? Do you have you seen the results? I personally use it, and I've seen good results in my scalp and very little DHT suppression in my bloodstream. So I wanted to know your thoughts.
Okay, Doc, I'll let you go.
Well, I think you have to take a step back before you answer this question. I always believe oral medications are preferable to, that's my own opinion. I do think that there's a certain amount of DHT that we know is produced in our bloodstream, and you need to suppress that. Not only at the level of the scalp. In my practice, I reserve these topical therapies more for people who do not respond to the orals. And I guess the question that I would have, or the answer I would have is, I personally, for many years, people pushed me to use topical treatments. Patients, why can't we have topical finasteride? I'm worried about the side effects. And the majority of them would try. And I'll come right out and say, I have nice hair. I have not had a transplant. I've been taking dutasteride for 20 years, and I have no side effects from it, and I've never had to have a procedure. And maybe one day, I'm not sure who will do it if I need to do it, but I haven't gotten there yet. So I'm a big believer in it. I do think that the side effects from oral finasteride and dutasteride are minimal. I do believe that 2% number is accurate. And the big thing that I'll say is that if people do have the side effects, in all the years between my father, myself, and all of our international colleagues, we have never really permanent side effects for oral medication. Nevertheless, I did recently start prescribing patients topical finasteride. I do mix it with minoxidil and Retin-A and anti-inflammatory like many other doctors do. And I will say that I was very shocked and impressed with the results. Dutasteride, I don't think it penetrates as well as the finasteride, so I think the vehicle really is what's important. So in at least my trials with the compounding pharmacy that I used, had better results with finasteride than dutasteride. But if it's working for you, fantastic.
Thank you, Doctor. And Joe, what are your thoughts?
Let's see, just checking my audio. Well, you're asking the thoughts between, or the differences between topical and oral topical and oral finasteride.
Oh, not the difference. I'm asking for your personal opinion. Have you ever seen results of topical dutasteride?
Oh.
Have you ever tried it?
Topical dutasteride is not nearly as, I'll say, available in all markets as topical finasteride. And I think there might be a couple of reasons for that. One of which is cost. I don't think that, I could be wrong. I'm spitballing on this just based on old information, but it could be more expensive. But I do know that it's just simply not studied nearly as much as finasteride. Finasteride is tried and true. Countless studies have been performed on finasteride and its efficacy for hair loss in all kinds of different scenarios. We know it's safe, relatively speaking, aside from the reported side effects that people talk about, some rare, some not so rare. When you look at the differences between dutasteride and finasteride, dutasteride blocking both 5-alpha reductase type 1 and type 2 enzyme activity on testosterone. There's more DHT reduction in some studies that, limited studies that we've seen, but there's also, in my view, I think that it might have something to do with some of the side effects that you don't really get with finasteride. And I don't know if Dr. Nussbaum's aware of this, and I can't cite the source. I can't remember where this comes from, but there was actually a side effect of reduced actual sperm count. Whereas when you're dealing with finasteride, you're dealing with reduced seminal fluid, which is two completely different things. Seminal fluid does not affect the ability for pregnancy except for the little swimmers to get where they need to be. But actual reduced sperm count, that's the big one. So there could be some sort of correlation with that. I don't know. I do know that there are some people out there trying to put out a topical dutasteride because of the perceived and in some cases recorded increased results compared to finasteride. But I think that it's simply not nearly looked at as, or I'll say studied enough as compared to finasteride. And a lot of the people that are putting together topical finasteride compounds are seeing really good results. Some are seeing not so great results, and so this is interesting. Their opinion of topical finasteride is kind of, I'll say, I don't want to say muted, but it's kind of neutral. Like you can take it or leave it. It's great for people that don't want to, suffer side effects from oral, but they think that the results aren't going to be quite as good. But I've seen other clinics that are using a different compounding pharmacy, and make no mistake, no two compounding pharmacies are the same. And all these topical formulations you see, there's going to be something different from one to the next. It can be the source of the finasteride itself, the quality of the finasteride. It can be the other agents that are involved in the final formulation, and all of those can have an outcome on the quality of the final outcome, or the aesthetic of the final outcome. I've seen some topical formulations. I'm actually saying, like, one doctor I know, I'm not going to go into it. I don't want to be in a promotional position right now, but one doctor that I know, he's got his own topical formulation, and it is really impressive to see. He keeps sending me
I know who you are referring to. I'm not going to speak either, but yeah.
Well, maybe. I don't know. You might. But I can say this. It's not someone I used to work for and no longer work for now. Okay? So just so you know, It's not that. It's not that formulation. It's another one. So
Okay, so it's not the one that I was thinking.
that's why I thought you might be thinking. Yeah. So yeah. I mean, there are good formulations. There are not so good formulations, and my opinion on them is that you need to find the right formulation when it comes to topical. Oral, you just need to look out for the type of, is it generic? Is it name brand? And if it's generic, which generic is it? I've talked about this ad nauseum. Like if you follow the Bald Truth of Spencer Coburn, you've heard me talk about it. You've heard him talk about it. When you're dealing with generics, you need to find one that works because not all of them do. Does that help?
Both answers make a lot of sense.
Okay. All right.
Thank you very much.
And I'll just quickly to coattail on that. The sperm side effects is real. So it scares me when I see dermatologists prescribing dutasteride to young men before they've even tried finasteride just because they think it's stronger. I think it's ridiculous. And my father was one of the first people to really notice that reduction in sperm count. In about 6 or 7 patients, he presented it at one of the meetings in the 90s, and it was a real thing. So we only give people dutasteride once they've failed, not generic finasteride, but brand Propecia. Then we'll consider putting them on dutasteride. And the only thing I've ever seen is that it will halt the progression of their hair loss, but not reverse it.
Right. Okay. Caller?
Thank you so much for your responses.
Okay. You got anything else for us? For Dr. Nusbaum?
Is there more people waiting? Because I have a second question.
Hey, ask any question you want. The floor is yours.
Okay, thank you so much.
Joe, there's a little bit of an echo.
Okay.
Is that me or is that you?
I think it's you.
Oh.
Yeah.
Okay.
It has it been consistent or is it just off
No, it
and
was
on?
in the beginning and
Okay, yeah, it's a system catching
it wasn't
up.
in the beginning and now it was in the end.
Okay, it'll fluctuate maybe. We'll see. Oh, Dr. Nussbaum, did you hear the question?
Nope.
Ah, okay. Cristobal, you want to try again?
Cristobal, try me one more time.
Can you hear me now?
Yes.
Okay, very good. I know Joe's opinion on this one, but I don't know yours. What are your thoughts realistically on low-level laser therapy? I bought Capillus, by the way, but is it comparable with the results of minoxidil? Is it complementary? What are your thoughts?
I would say that with low-level laser, I think it is probably a fourth-line therapy. I think it is definitely behind the 5-alpha reductase inhibitors, inferior to PRPNA cell if done in the right hands and with the right systems, and inferior to topical monoclonal. However, what we always tell patients is that the more treatment that somebody is willing to do, the better. And I have seen some nice results, mostly in patients with lighter colored hair or in the crown. I do not think it's effective in the front of the scalp, and I think it's really for people who don't want to use 5-alpha reductase inhibitors. I like them to go full court press with everything else.
Yeah, makes sense.
So okay. I think it works. I don't think it's nothing, but I don't think it's anywhere equal to those more proven big guns.
Perfect.
All right.
That's more or less Joe's opinion, I think.
Yeah, pretty much. He got it.
I agree.
All right. Any other
Thank you
questions?
so much to both.
All right.
Those were my questions.
All right. Thanks for calling.
Thanks for your help.
Bye-bye. So, Doc, I got a question about the ARTIS robot, and you're one of the doctors I work with that has been using the ARTIS for quite a while. You've got a good relationship, a close relationship with the manufacturer, Venus Concepts, and I'm sure ARTIS before Venus actually purchased them. And you're running are you running the IXI yet? You are. Okay. Okay. So you got two of the IXIs, and for those of you watching, the IXI was just recently released, and I remember actually seeing a prototype. The manufacturers invited me to an event. I think it was last fall. They had a prototype that they were showing during a dinner, and I can definitely see the improvements. It's pretty cool. You've got two of these. So aside from just IXI, I'm not looking to get into that, but just ARTIS in general has, for some people, a negative stigma. And I'm not saying I don't understand why. Of course I understand why. And, I've talked about it. Spencer's talked about it. And my position, when people will even bring up you or any other, like, say, IAHRS member that uses it, and my position on this is that the tool is only as good as the hand that wields it, including a robot. If you have an understanding of hair restoration surgery to begin with, then it can be just as good as any other tool because you're experienced. You understand its limitations. You understand what it can do, what it can't do. I'd like to hear from you, so that it's on record, so that people can hear it from you. How do you use it? When do you use it? When do you not use it? What's your, tell us about your feelings about the robot.
So we've done more cases with the robot in my practice than anybody in the world since 2011. We were one of the few practices that stuck through the sort of steep learning curve and all the trials and tribulations with some of these older versions. Everybody bought it at the beginning, and within 6 months, they put it in the back corner. We have sort of stuck with the device.
Yeah.
So I have seen dramatic advances in it over the course, even since I started doing surgery about 7 or 8 years ago.
Mm-hmm.
What I'll say now is that if you and I don't want to get into the jurisdictional things about who's supposed to be doing what, because things are different in every state, but here in Florida, it is the law that a doctor, nurse practitioner, or medical or physician assistant is the only people that are allowed to cut your skin. While I have no doubt that my team of 20-year experienced hair transplant technicians are capable of punching grafts out, they don't do it in my office. And what we have found is that the robot allows for the precision and the accuracy of the procedure to remain intact throughout the whole donor harvesting process without relying on somebody's physical eyes, back, neck, etc.
Mm-hmm.
And what I have also found during these times is the limitations of the robot. So I now am doing sort of what I call hybrid FUE on every patient. So I'm doing about 70 to 80% of the case with the robot. I do think it is faster than manual FUE, and I believe in my hands it is more precise than manual FUE. So I will do the majority of the case using the robot. I only use the small, 19 gauge needle. I do not use that large punch, that the famous pictures of people comparing punch sizes to one another. I do not use that. I only use the smaller needle, and I do about 70 or 80% of the case with the robot. And then I do manual FUE on every single patient to sort of feather and blend the borders of where the robot took from, so you don't sort of get this linear rectangular harvest in the donor area, which a lot of people were. I feel like everything that people complain about the robot about, the punch size, the linear harvesting, I have, in my practice at least, I have dealt with every one of those negative feedback. So I upfront tell patients, if you go down the rabbit hole and you start reading, you're going to read bad publicity about the robot. Unfortunately, I think the company tries to sell their device to a lot of these med spas and people that are just trying to make, do hair transplants as a secondary source of income. So I think it gets a bad rap because of their results. But I think the way that I am using it, I think it's fantastic. And what the company probably doesn't want me to say, I have had the company delete all of the factory presets on my machines, and I am allowed to run it however I want. So that's why when you get a robotic transplant in my office, it's not the same as getting a robotic transplant somewhere else.
See, I didn't know that you had more freedom like that. But you're talking about the company and what you're allowed to do, what you're not allowed to do. I appreciate that. I appreciate that you went and said what you said. But what I've noticed, and I understand why they sell into med spas. I understand why they're selling to these clinics that may not have the experience that obviously you would have, or even just a typical hair transplant surgeon's been doing this for a while. They want to move units. You can't, as a company, you can't blame them for that. But my problem is, I think that when you're dealing with something that has such a large learning curve, that is hair transplant surgery, I think that it's hard to really put this into words properly, but I don't think that's the right move, and I don't see how that could be a long-term or that could be worked into a long-term plan for growth, which is what every business is looking for. I know that they've adjusted the pricing on their consumables and how things work in that front. And just for the audience listening, when device makers such as Venus Concepts, who now has Artist Robot, or say SmartGraft or NeoGraft, or insert name graft here for a device, they're not just selling the device, the machine, to the clinic. They're selling consumables, and in some cases a service package to maintain that device, so that they can continue to generate reliable revenue. And it's based on how many grafts. It's kind of like the printer and copy model from the IT world, where you're charged per graft, or in the case of some systems, an attempt. It doesn't have to be a successful extraction. It just has to be an attempt, and they charge the clinic for that attempt. And so, in talking to Dr. Nusbaum, whoops, sorry, I think I lost the sound. Hold on.
I'm good.
There you are. Okay. He was talking. What were we going to say? Sorry. I saw the hand waving. Yeah. Were you trying to say something?
In my office. That's why I muted it. It wasn't you guys.
Oh, God. I was like, but the sound setting's on. What's going on here? It was you. Okay. But yeah, I think what you're saying, ties into that, where they do sell into these other clinics, these med spas, whatever you want to call them. And I don't see that as a long-term sustainable model where they would have to kind of wind down on building these devices, because how many can they move? How many can they sell?
It's not my place, of course, to I am not a businessman. I have absolutely no interest in their company whatsoever. I can just tell you that and I agree. I couldn't agree with you more. And I think by selling the robots to inexperienced clinics and things like that, they're actually making it harder for the couple, because I'm not the only one. There is 2 or 3, doctors in the United States that I think use the robot very well. And I think that they're making it harder for us to, sell their product and not sell their product, but convince patients to have a procedure with us, because they're kind of their secondary actions. Mm-hmm. However, I can say, probably because of the volume of the procedures that I do and the results that I'm able to put out with their devices, they've been, nothing but good with me,
Yeah.
trying to foster their relationship. And what I tell patients is, look, you have to have trust in the doctor that you're going to develop this lifelong relationship with, because that's really what this is in hair transplants. And, you know, if people are going to come into my office after seeing my results, I'm have no problem answering questions and concerns about the robot and thing. But if people are not going to trust, you know, trust what they're going to get in a particular doctor's hands, then, you know, then I think the doctor-patient relationship is kind of not getting started off on a right foot, is what
Yeah,
I'm sort of saying.
that makes sense.
You have to have trust in the doctor. You have to look at their results. You have to look at their credentials. And then you have to say, I've seen the most natural, beautiful hairlines. I've seen beautiful results. You know, people rave about you. You know, I know I'm not an expert. You are. Let me, I trust you to do whatever you feel like is going to be best for me. And those are the patients that us doctors really appreciate and really want, is what I would say. So I try to not but it is a question I get asked probably 3 times a day.
Well, it's a great point that you're making about, or a great comment that you're making about what doctors appreciate. But the question is, how do patients become educated? How do patients learn what is actually natural? And I say that because I don't know if you heard you probably didn't hear the I'll call it the monologue before you came on board. I'm seeing more and more of people out in the wild on the different interwebs formats, different platforms, looking at results that are literally identical to what I had done 31 years ago.
But the hair grew.
Yeah. But how are you educating people on what natural is, or what constitutes a good education on for a patient before they even get to you, to where you don't have to sit there and go through the basics over the course of an hour, which you and I both know you can't actually cover that in an hour, much less a full day or a week. You know, so how do you quantify that when a patient is educated?
I mean, I don't know if this is the exact answer to that question, but what I would say is that you know, the majority of people, unfortunately, don't know the difference between what's good and what's not good, and what's natural and what isn't, which is, I guess, I'm restating the problem that you already know exists.
Yeah.
And I would mostly say that, you know, that's why, you know, us doctors in the field are fortunate to have places and people like you and like Spencer and that are doing their best to educate patients on this. I don't know how to further, you know, there's always going to be clinics and there's always going to be people posting their results on Reddit and online that are going to be raving about these thick, straight Mickey Mouse hairlines. And, you know, people are going to think, oh my God, the hair grew. It's fantastic. And I mean, it's a very frustrating, you know, I mean, I show people my before and afters. I show people the irregularities that I draw in the hairline, which is, I think I'm one of the few people to maybe actually do that instead of just free-handed. And I try to explain to them that in the first part of the hairline, I sort of show them my hairline. And I say, look at mine. There's single hairs in the front. It's a little fine and thin at the very beginning. And then the density starts behind there.
Yeah.
You know, so it's hard to get people to sort of understand that. It's a challenge that we have. But, you know, it's sad more than anything to see the amount of people that they don't really know what good or not good is.
Yeah, no,
so I know that there's a problem there. The answer to that, I don't really have it. You know.
Yeah, and that's well said.
I need to step away for 2 seconds, Joe. I will be right back. Okay.
Yeah, no worries.
I'll be right in.
Thank you. All right. All right. Thanks everyone for sticking with us here. And I do apologize about some of the echo that was going on earlier. It's my inputs for the phone call and having Dr. Nusbaum at the same time. But I know there are some questions in the chat room that I will be getting to with Dr. Nusbaum once he returns. As I said at the top of the show, top of the hour, he would probably have to step away because I think he's discharging a patient that was getting finished up when he came in. So we certainly appreciate Dr. Nusbaum for joining us. Hopefully he'll be back shortly. In the meantime, don't forget, click that like button, people. This is the inaugural broadcast of the main event, and so happy to have a great guest like Dr. Nussbaum. I don't think he's been on any sort. I know he's been on maybe a couple of, at least one I can think of, broadcast with Spencer Coburn. But as far outside of that one, I don't think he's been anywhere for some sort of interview or discussion like this. So really pleased to have him with us. Considered a great pleasure. He's a really nice guy too. Like if you're able to get to know him, he's a good guy to get to know. And let's see, let's go to some questions here. Yeah, Sergey's asking about Dr. Nussbaum's safe upper limit for density. We'll check that one out. Hey Graham, thanks for joining. Good to see you, buddy. David Anthony says wants to know from the doctor. He understands there's no shampoo out there that can slow or help with hair loss. Correct? Question mark. Either way, can you recommend a good shampoo for scalp that gets itchy, irritated after washing? Personally, I like Nizoral 2%, which is in some places you got to have a prescription for that. Not here in Canada, or at least in British Columbia. I have 2% myself, and I really got into that at one point because I did have an issue with itchy scalp and worse, where I had psoriasis of the scalp. This was many years ago. And if it does get severe, you could look at a tar-based shampoo. You can look up Tardan. Don't ask me about the name. Tardan is the name of the shampoo. It's an amazing shampoo, tar-based. And yes, I do mean tar, like coal tar, which is bizarre, but it works. It's really good for reducing the itch. And if you got flakiness and stuff like that, it's really good. It's an extreme treatment that's quite good. How would the doctor deal with someone who's 25, Norwood 4? Yeah, thinning parietal humps. Good word. You've been reading. Destined to be Norwood 7 by 3 surgeons. Wow. Yeah, that would be, hopefully you're taking medication. You didn't say, this is for Sam Ali. Sam Ali, you didn't mention anything about medications. Hopefully you are taking medications. We'll try to get the doc back to that as soon as we get back. There's some other questions up here. Let's see. Thank you for the additional likes. And of course, also don't forget subscribe if you haven't subscribed, and ring that bell for notifications, because I'm doing this daily, folks. I still don't know who I'm going to try to get in tomorrow. Dr. Nussbaum coming on I only thought of it. He was the first doctor I reached out to that I work with, and he just happened to have availability, and that was a 3-hour notice. So I really appreciate him on that. And looks like he's back. All right.
Hi, guys.
Doc, welcome back.
Sorry about that.
No worries. Okay, so we got some questions here that we were just kind of perusing over while you stepped away. And there's one that I'm really curious about your answer on this. And Sergey, who's a regular follower of my channel, certainly appreciate him. He asked, what's the upper limit of density that you'll transplant on a hairline?
40.
40.
40 follicular units per centimeter squared. Now, I don't really measure this. You know, I'm not somebody that draws boxes and really measures it. But when I'm doing estimated graph numbers, depending on, obviously it all depends on the donor hair. You know, if they have fine hair, if they have coarse hair, how low you're bringing the hairline. Is it dark hair and light skin? What are the patient's expectations? But I really don't. I think that, you know, you're at a higher risk for necrosis with packing sites closer. And I think, you know, there is some truth that if you overpack grafts, I do think that the growth is affected a little bit. Yeah. My philosophy, I wear, you know, I have 5 different pairs of loops, anywhere from 2.5 to 6.5. I usually make sites with a 3.5 or a 4.5. And my kind of motto is, if you can see a space with a 3.5 loop, there's a space and you need to put another graft in there. So that's kind of my, you know,
that makes sense.
Space, there's a space. So I don't really think about it in numbers wise. Obviously, I think you need to be a lot more careful in the frontal tuft, because that's more prone to necrosis. So it's really the type of patient, the skin, the scalp thickness. We're actually doing a study right now and this is off topic, but looking at ultrasound and looking at scalp oximetry intraoperatively to determine, is there sort of a safe limit of, you know, does the oxygen saturation in the scalp go down after epinephrine? Does it go down after site creation? So we're trying to look at all these things in a little bit. Nobody really knows about this, but we just started doing it. And we
Awesome.
have some interesting data that we've recently found, and we hope to publish soon.
Can you talk a little bit about the differences in blood flow, the vascularity of different areas of the scalp, say the occipital region on up into, like, I know, but I don't know about the audience, about the two main arteries that coming up in the back occipital region through the top.
Correct.
But then, as far as the distribution of the venous system throughout the top, how does that differentiate through different areas?
Well, the main, and I don't know if this is the answer your question, but the main area that you need to be careful of is the watershed area in the frontal tuft.
Mm-hmm.
There's the old saying of how many vessels do you need to supply the scalp? You really only need one. You could clip everything else, and 1 out of the 4 could properly survive it, allow blood flow properly to the scalp. I, knock on wood, have never had a case of necrosis up to now. I do not use epinephrine. Most people use epinephrine in their saline tumescence, in their tumescent solutions.
Right.
I like bleeding. I prefer the scalp to bleed and to have a little bit of a hard time seeing, and to have to come back 2 or 3 times rather than blanching the whole scalp and having an easy time making sites and then worrying about vascularity.
Right.
In addition, because I am dense packing, or what I consider to be dense packing, not quantifiable, but I use mostly saline tumescence. I do not like to use epinephrine. In my earlier days of doing procedures, I did have a couple times where the skin did turn a little bit white or purplish, and I kind of backed off on the density and everything turned out fine. But it kind of taught me that lesson that it's better to have a little bit more blood there and struggle a little bit more with visualization, and just have to make, instead of making sites all in one shot, you may have to come back a second or a third time. But I'm really not using a lot of epinephrine at all, really, in my tumescence.
Right.
And I'm actually finding that without using a lot of tumescence, my patients really aren't getting swollen at all, which it's funny because, and I know this is off topic, but no matter how good of a result you give a patient, they always remember if they got swollen after.
Of course. Yeah. No, that's yeah. I don't remember this, that, or the other, but boy,
great,
do I get swelled up.
Swollen after.
Yeah, exactly.
So.
Okay, so great answer. Appreciate that. But my next question, and I'm really curious about this. What can you talk about when it comes to, what can you say when it comes to tissue integrity with higher densities?
Meaning what? Elaborate on the question.
Yeah,
Sorry.
meaning the tissue integrity, the connective tissue between 2 incisions.
Quality work that is expected of the majority of patients today. So, I mean, it's almost like, I don't know whether patients want to start asking doctors, how big are your loops that you use? But I know everybody's eyesight's different, but I found that using a regular 2.5 loop, which is traditionally what most people use, it's what my father used for a million years. I don't think it's enough for these days. And I think with higher magnification and kind of being a little bit more careful, you can avoid making what I think Joe is referring to, the higher density pack. If you connect one site to the other, you really, instead of making 2 1-millimeter incisions, you just made a 2-millimeter incision. And that tremendously affects the vasculature, the connective tissue. The other part is, if you put 2 grafts in there, then it's going to clump together and it's going to create like a plug or like a mini graft. Do you only put 1? Does it stop bleeding? But it definitely is a big risk factor for, tissue integrity, vascular issues, and stuff like that. So,
right. And in fact, it
bothers
actually,
me when people ask me how high not only bothered, my patients are like, how dense is my hairline going to be? So how many follicles do you implant? It's like, we're going to fill it up as much as it can be filled up to where you still have good vascularity, the grafts grow, and it's a thick enough result to where you're going to be happy with it.
Yeah, exactly. But let's not forget, using 1 millimeter as an example. If you got 2 1-millimeter incisions, and then that connective tissue dissolves in between, it's 2 millimeters plus the distance between the 2 incisions to begin with. So it's even larger. And yeah, so I brought that up because I wanted a respected doctor to discuss this, because I've discussed it many times, and I've had people question, well, that doesn't make any sense. Like, why would the skin just, fall apart? And it's like, well, because that's what happens.
Right.
What's that?
No, it absolutely does. And you also have to remember that everybody wants the dense hairline, but the vascularity comes from here. So the thicker you know, pack your sites, or the denser you pack your sites in the frontal region, that's why you got to worry about everything behind there.
Yeah.
So you're kind of like creating a wall to all the blood flow. And
Of course.
the other thing you got to be careful with: previous scars, previous scalp surgery, diabetics, multiple skin cancers, things like that. And like I said, we're trying to create an easy way for doctors using something called durometry to see if it correlates with ultrasound, to have a quick and easy way to determine scalp thickness preoperatively, to sort of determine how densely packed you can make your sites without risking vascular compromise.
Right. Yeah. Which is, yeah. And that's, it'd be nice to be able to have a whole suite of imaging equipment at our disposal, in a hair transplant OR suite. So, so another question, and this is, I don't even know the answer to this one, but someone was asking, what's the largest session you've performed? And I guess we can segment that into FUT and then FUE surgeries.
So the largest sessions that I have performed, I've done probably, I can think of one particular strip procedure was around 3,500 grafts. He had, his donor density was in the hundreds, with super elasticity, and we were able to get somewhere around 3,400 grafts or something like that.
Right.
He was a type 6. He did come back for a second procedure. We were able to get another 3,000 grafts or something like that. So this is the one guy that comes every year to your office that you say you have donor for 3 people, and that's what I literally tell them. You look at this big blockhead and this super thick hair, and you're like, wow, I wish everybody had donor hair like you.
Yeah.
In terms of FUE procedures, I have not really pushed, and this is rare. I mean, my normal average size case is, 2,300 or so, like that, on the majority of people. The largest cases FUE I perform is about 2,800.
Okay.
And
in one
really
sitting.
In one session, yes. So 25, 26, I've done that several times. I got 2,800 once I can think of recently, and with a strip a little bit over, like I said, 3,400. And everybody comes in and says, well, if I'm going to do the front, you want me to do the front first, and then you want me to come back and do the back. Why can't you do it all in one session? Which is what every patient's question is. The main thing that everybody forgets is, what's the main risk? When people say, what's the worst thing that could happen in a hair transplant procedure? What is the danger of doing this? You can have a reaction to the local anesthesia, which is the same thing that can happen in the chair of a dentist, but these huge, large, mega, giga, whatever you want to call it, sessions, you need to keep the patient anesthetized and comfortable throughout the procedure. If not, it just becomes torturous for everybody. And, there is limits to how much anesthesia a person is supposed to have in a daily basis.
Yeah.
So, I do think a lot of times people are ignoring that, and they're just doing, and that's kind of where problems happen. And the other part about it is, to do a 2,800 graft case, it may be very well every bit of 10 hours. How much can a patient really tolerate, in a day? Yeah. So these 4,000 grafts, and I see a lot of it. I'm suspicious of a lot of doctors really chopping grafts down, which I think is another problem that I see a lot, that they say, well, the doctor said I did 3,000 or 4,000 grafts. You look at their donor area, and there's no more than 1,900 that were punched. And that the guy's super thin because they broke down all the 3s and the 4s. And they made a bunch of singles and made the number go up and told the guy he got 3,000. So, it's tough, but those are the largest sessions, just to answer the question.
Fair enough. Okay. All right. Next question. Sorry, how much, are you good on time?
I'm good.
Okay. All right. Next question was, let me see if I can find this. Okay, so this is a pretty easy question, or maybe it's not. David Anthony asks, hi, doctor. I understand there's no shampoo out there that can slow or help with hair loss. Either way, can you recommend a good shampoo for scalp that gets itchy and irritated after washing? And you're in luck, David Anthony, because Dr. Nusbaum is also a dermatologist.
Thank you, and I agree with your first statement 150%. My joke to people, which is a complete joke, I'll say it, is there's the bet, until I have Dr. Nussbaum shampoo, you can use whatever shampoo you want, but that's only a joke. So the bottom line is that there is no shampoo that really, in my opinion, is truly effective to regrow hair. If you think about shampoo, you put it on your scalp for, 5 minutes, 2 minutes, you rinse it off. It's not there long enough to absorb into the scalp. So any shampoo that's claiming hair growth, I think you got to kind of call it out as bogus.
Well, just to
What
clarify,
I will say,
he's talking about itchy, irritated scalp.
okay, so what would work for itchy, irritated scalp?
Yeah, that's what he's
So
looking at.
there's number one, we always say, you probably should, and this isn't the plug for the dermatologist, but you probably should get if you're having itchy, sensitive scalp, you probably would, instead of just treating it with whatever shampoo I tell you to use, and I can list a couple of them without an issue, you probably do need to be seen by a doctor because it's not normal to have itchy, sensitive scalp. You may have just routine seborrheic dermatitis, for which they could prescribe you prescription ketoconazole or Nizoral shampoo that also is available in a 1% formulation over the counter, or things like Neutrogena T-Gel or T-Sal. That often will help with sort of seborrheic dermatitis. However, a lot of patients think they have just dandruff or seborrheic dermatitis, itchy scalp, and they actually have more of an inflammatory scalp condition like lichen planopilaris, where just a simple shampoo is not going to treat that. So what I would say is if you're having itchy, sensitive scalp, it's worth a visit, even if it's just one visit to your dermatologist, to make sure that they diagnose you correctly. And then, there are prescription shampoos like the ones that I mentioned, and there are some other over-the-counter ones that will help. But it always worries me to give kind of general advice for cases like this because I would want to see there's always something going on in the scalp, and I think it's better to have it looked at than just buying an over-the-counter shampoo.
Okay, that's a great answer, and you also and you made me think of another question that I'm genuinely interested in because I'm not following it too much. But before I get to it, I'd like to remind everyone to please hit that like button. We've got Dr. Aron Nusbaum from MiamiHair.com in Miami, Florida. Hair Transplant Mentor, accepted member, IAHRS, American Hair Loss Association recommended. Really appreciate you being here, Doc. You're doing me a solid. That's awesome. So, yeah, you mentioned lichen planopilaris, the old LPP. What's going on with that? And I ask because I remember when this first was being discussed. I don't know. I can't say, in general across the board in the industry, but I remember coming across a patient around 2006-ish, 2007, that was having some symptoms, and through some research and I was helping the docs with this. It did come up to be diagnosed eventually by a dermatologist through biopsy to be LPP. And I've been seeing more about this. I've been hearing more doctors throwing that out as a possible diagnosis of an issue. And my question is it actually that prevalent where people are getting it and they don't even realize it before, without a surgery? And before you answer that, the way I understand it, that people develop symptoms of LPP usually because of some sort of trauma to the skin. Is that correct? Is that still the case? And is it becoming more prevalent than in the past, or are we just learning more about it and finding out that more people have it than we realized?
So, great topic, and I love talking about this. So I'm glad we brought it up. We did a study. I'll always start with data. We looked at all our consultations in a year, 1,000 consultations. 3% of the patients that came into our office basically had lichen planopilaris, which if you think 3%, it doesn't sound like a lot, but that's 30 patients that would have been incorrectly operated on. Mm-hmm. And that number, when you think about it like that, that's a lot of people to make a mistake on.
Of course, yeah.
So that number is high. We did look at some other like tertiary research and university centers, and we found that there was sort of a reported range of the incidence of LPP to be around 3%. So I don't know that it's getting more prevalent. I personally believe it's on people's radar more, and hopefully people are getting better at diagnosing it. My whole thing, and I've given lectures about this, everybody uses a dermatoscope or a video microscope, most people, I hope, to look at a patient's donor area in a consultation. But how many people actually take that microscope and look at the patient's top of their scalp? In my opinion, a hair transplant surgeon needs to have a full and complete, thorough understanding of dermoscopy and hair loss dermatology or hair and scalp disorders. That's why when I see some of these, and I'm not discounting anybody because people may be able to do great work, but people like urologists or emergency medicine doctors that haven't really had training in these things, that it starts to scare me. So what I will say is if you're doing hair transplants, you need to know how to use a dermatoscope. You need to look at the recipient area in every single patient, and you should be super suspicious about LPP. I think also, and that's LPP can not only arise after transplant, it absolutely can be de novo. We do not understand why. It's just your body produces some sort of inflammatory response that attacks hair follicles, and little by little will end up destroying them.
Yeah.
My belief is that instead of the transplant causing the LPP, my belief is that it was I think more of these patients that are being called LPP after transplant really were just either it was subclinical or it was misdiagnosed or undiagnosed by the transplant.
Yeah.
So that's really my hypothesis to this whole thing. And I think it is a real thing. It scares me, because I think a lot more people have it. And, I mean, it's funny because it can be after transplant. It can be before a transplant. It's always the guys that have great donors. I'm making a joke, but an incredible donor area, you're going to knock this case out of the park. And then you look and you're like, oh. So everybody needs to be suspicious for it. I think it is out there. And I think, I think that's another thing to educate patients. And I'll make one sort of aside on this. In this day and age of doing these virtual consultations that started during COVID, I've had to send people home the day because they flew from across the country to come see me, and the day before they come in for a consult, and this is what they have. So be cautious about doing online consultations. Maybe one of the things to screen, amongst the list of, are they, IAHRS members? Do they exclusively practice hair? Do they have a full-time staff? What are their results like? Do they know how to use a dermatoscope, and are they going to examine my whole head in a consultation? So, that's something that's super, super important. Nobody wants to spend time, energy, and money and recover from a procedure just to have it, not turn out well.
Of course. And just one final question on the causes, like we're talking about the trauma, and it may not be just from the hair transplant. It can actually manifest after the fact, maybe from some other physical trauma, after everything's grown in, it looks beautiful. This is a case actually I remember that got me interested in this, and I started learning about LPP. Was a case where the result came in, it looked fantastic, but then maybe a year after, he slowly began to lose all of his transplanted hair because of LPP, and that's when I started learning about how it can manifest through some sort of post-traumatic recovery. To the scalp or to the head or wherever it's manifesting. But my question is, what's causing this inflammation? Directly, is it an overcompensation by the body to deal with whatever this trauma is, akin to scar formation during a cut? And is this inflammation maybe caused by, could it be a nutritional element that's causing this? Because I'm seeing, or I believe, that a lot of the inflammation that we're having externally and internally, more importantly, is because of the nutritional element that we're all subjected to with processed foods, of what are they called, life chemicals or what have you, that our bodies constantly trying to fight off as foreign bodies. Your comment, please.
I don't think anybody knows the answer to the question, and that's why it is a good question, of course, because we don't know yet. The only sort of similarities or studies that sort of have been done at this point, there were some genes identified in LPP. It was PPAR gamma, I believe, and they started treating with pioglitazone, which is a medication for diabetes, I think, because it blocked this. Of course, a lot of patients had some side effects, so they didn't. So there is possibly they found some genetic component to it or gene dysregulation at one point. But along the lines of the nutrition and the chemicals, it brings us to the cousin of LPP, which is frontal fibrosing alopecia, or
Right,
FFA.
right.
And there have been studies, they're not the best studies because they're more retrospective, but they have found sort of an association between certain types of cosmetic products or chemicals, mostly in chemical sunscreens and certain makeups and things like that. So
Right.
I certainly, and in a textbook, lichen planopilaris and LPP are indistinguishable histologically. So it is possible that there is some sort of chemical stimulus. I do not know that the body's response to the trauma has truly been elucidated, but I would expect it's some sort of inflammatory cascade that for some reason sets it off and wants to eat up those hair follicles.
Okay, that's good. That's good. I think it's enough LPP for today. We'll move on to the next question. Let's see. We got Al Franny wants to know what your thoughts are on microneedling. Does it make any difference?
I am not a big fan of microneedling. This is my personal opinion. I'm not telling you that it doesn't increase penetration and stuff, but I have seen bad cases of telogen effluvium from people who have overly aggressively microneedled areas. Basically, if you think about it, it's a bunch of uncontrolled needles going all over the scalp.
Mhm.
I know you can set how deep or not, but I mean, I saw one year, I think, or in a couple month period, it was 4 or 5 patients that started doing microneedling, and they all were coming back with like horrible shock loss, basically shedding tons and tons and tons of hair from it. So I personally am not a big believer in it. I think that there is some science about the Wnt pathway and inducing the wound healing cascade by creating some trauma regenerative properties. I don't think that I don't think it's going to regrow hair out of just a completely bald patch of skin. And I think if you're looking to use it to increase the penetration of topical therapies, that's where additional medications such as tretinoin or retinoic acid or things like that can help do that without causing unnecessary trauma to the scalp.
Right.
I also never understood people who do PRP with microneedling, because how do you really know that it's absorbing into the scalp? So that was kind of I'm not a big believer in it, to give you the short.
I think that came through loud and clear. That's good. It's interesting. My ideas on wound healing or wound-induced hair growth. Sorry, wound healing. Wound-induced hair growth actually changed when I wiped out on my road bike, and I ripped up my knee pretty bad. Not the kneecap itself, but my skin, and it was pretty bare, being right below my kneecap. And as it healed over the next following months, and it's still there, a significant amount of hair that a bald person would be happy with if their scalp was like that big,
Right.
grew, and it's still there. And it really shocked me, to where it's like, okay, maybe there is something to wounding for hair loss, right? So, interesting. Like all that's really interesting to me. Let's move on to this is a good question now. Guy in the chat room, my boy FSK, he wants to know: have you ever done a strip after someone had a previously large FUE session, and if so, how did it end up in terms of the way that the donor area looked? What were the aesthetics of the donor area after that?
Well, the answer is yes. I actually did a procedure last week, the same exact thing that was last Monday, actually. So I don't quite understand what it means by how the donor area looked, but what I will tell you, the considerations were, now that you've had FUE done in the donor, obviously the density in the donor area has gone down. So it depends really how much hair somebody needs. But I was able, like in this particular patient, he had around a 2,000 or 2,500 graft FUE procedure. He wasn't really thrilled with his results. He wore long hair at the time, so he didn't really want to have to go through the, shaving of the scalp to do it. And he didn't want to, quite go for a no shave FUE procedure. So we ended up doing a strip, and I was able to get, I think, 2,100 grafts out of him, and he had a great result. And I have not seen, and I can think of probably 10 or 15 patients that I've done this on. I have not seen any difference in the overall healing of the scars or anything like that after doing that type of work.
Now, regarding, okay, so thank you for that answer. That's a really good answer. And my question is, when you're getting patients in that have had previous FUE surgeries where the extractions were through the sweet spot that you're going to take your strip from, when you're bisecting that tissue, which is a thing of beauty for me. I love watching that. What are you seeing with the angles of those grafts that are going to be taken out on either side, like on the side of the strip removal, and then on the inner wall of the occipital that's not being removed? What are you seeing with the angles of those follicles underneath the tissue?
They're all distorted, but it's no different than what I see doing a second strip on a patient. So, when people have previous strip procedures, I am of the belief I don't create a new scar. I continue going over the same area. And if the patient has 3 strips, he has 1 line. So I would actually not to do this to you, Joe, but I would turn this the other way around. I don't think it really affects anything more than it's similar to doing there's more adherent tissue. There's a little bit more blood vessels in there. The follicular architecture is disrupted a little bit, but it's no different. It's probably less so than the follicular architecture disruption than somebody who had a previous bad large strip procedure is what I would say. Now, the other side of this is what about, and I'm sorry to turn the question around, but doing FUE in patients that have had previous strip procedures. That has been challenging for me, more so than doing the strip in a previous FUE patient. I have found, and that's one area, I'm giving a lecture coming up on about this, in people who have had previous strip procedures, I feel like, a lot of times around that scar area, I do not find that the robot works very well. And that's an area where I usually will do more manual FUE, and it's a lot more challenging. So
is that because of the distortion of the angles? Yeah. Okay. That makes a lot of sense.
Scar tissue and everything. So I think it's worse to do an FUE after somebody who's had a bunch of strips than it is to do a strip and somebody who's had a bunch of FUEs.
Well, doesn't that depend on how close the extractions are to the?
Absolutely.
Yeah. Okay. Yeah. Because what I've been saying to people, and and based on my own experience, is if you can go strip first for one or two strips and then switch over to FUE, then that can potentially help you get a larger overall number of grafts for the long term. Sorry?
I say the same thing to my patients.
Yeah, and I use my and it's not this, not across the board for everyone, and some people are absolutely against any sort of strip, and that I completely respect that. So at least one of the doctors, another hair transplant member doctor would be yelling at me if you heard me saying this, but I do respect that. But the case I refer to is my own. I've had 7 strips. I've had 7 strips, including a revision, and the follow-ups after that were FUE, and I still have more in the bank, but I could get more strip, but at this point it would only be on the bilateral donor regions. The occipital would be left alone, but I don't want to risk it. Like I've had so much, I don't want to risk it, and FUE would be the only opportunity or offering I would accept moving forward if I were to have more surgery. So, it's very curious to me. It's a very interesting subject where someone does have strip first and then FUE to get one's take on it. And I really appreciate your take on that. Let's go to some questions. We got half an hour left for the broadcast. Are you game for sticking around?
I'm okay. Yeah, Joe. Of course.
All right. Right on. So before I do, everyone hit that like button. If you haven't hit the like button yet, please do. If you have hit it, don't hit it again, because that kind of takes it away. So hit that like button for me, folks. I'm here with Dr. Aron Nusbaum, Hair Transplant Mentor, accepted member down in Miami, Florida, IAHRS member, and second generation hair transplant surgeon. I think that's just like a great story. I love that story. Why don't you tell that like real quick? Like I wrote about it when I first brought you on board as a mentor member, but I'd like for you to tell everyone. I think it's a cool story.
So, I always grew up, my dad was always the nice one and my mother was always the mean one. So I always spent all my weekends with my father.
I didn't write that part.
Yeah, well, I'm telling you, I'm adding some, material to the story. And, on the weekends when he would come into the office, and any opportunity I had over the summers or anything, I was basically my father's shadow. So when I was young, 3, 4, 5 years old, he used to, when he was seeing patients, he would pull a couple of his own hair follicles out and stick them under a microscope and have me sit there and play with them. So I was kind of born and raised. My joke is that it's pretty true, actually. The Nusbaums, I think, were put on this earth to do hair transplants to take care of hair loss patients. So I truly feel like it was in my blood, and I always knew I wanted to do this. And really what made the lasting impression on me was, no matter where I went with my father on the weekends, whether we were at the movies or getting something to eat or riding around town, there was never a day that 2 or 3 patients didn't come up to my father and say, "Oh my God, Bernie, look at my hair. Look what you did for me. You changed my life." And I, as this young, impressionable kid, just basically saw that. And growing up, I said, I got to be like this guy. So I spent every summer, my whole life listening to my father and giving me all these surgical pearls and watching it in person, working as a technician in the clinic until I guess my day came and here I am, and the rest is kind of history. So
right on. Yeah, it's a great story.
Beautiful transition, and it truly is a blessing, and I know for him it is too, to sort of live off of his legacy, and hopefully when I have some kids, we'll do the same thing, and we'll have the third generation.
Third gen, right on. I do have a question that I've been talking about lately, and it's interesting to me. I made this video several years ago. I forgot how long ago it was, where I was talking about the importance of microscopes in hair restoration surgery. And for you, this is like old hat. It's like, why would you even need to talk about that? Like, it's a given, right? But it's interesting, the response I got on that. It's got just under 650,000 views since I first published it. And I think because part of it's kind of a new concept a lot of people didn't even know about, because when you look at the proliferation of all these FUE shops that open up overnight, you want me to invest in microscopes? Why would I do that? I can pull out single hair grafts. I can do this, that, and the other. So with that in mind, I got one question for you. I know what the answer is going to be, but I want you to answer it and then expound upon it. And it has to do with what I see people saying. I know they've watched my video. A lot of people watched it, and it has helped with the awareness of the need for microscopes. But what I see people saying, and I'm talking about how they type things out, they talk about microscopes are necessary for sorting grafts. True or untrue?
Only or including?
They're needed to sort grafts.
They're needed for everything. They're needed to,
please expound.
That's my opinion.
No, expound on that. Yeah. It's not just sorting. Expound on the use of microscopes in hair restoration surgery.
If you're doing a strip, you cannot sliver a strip or dissect the follicular units out of a strip without a microscope. That's a given. You cannot do it well enough with goggles or anything like that.
Right.
Without a microscope, you're going to cause a lot of transection, whether it's during the slivering or the separation of the follicular units.
Of course.
So not only are you going to cause transection, but without a microscope, you're going to incorrectly, you're not going to see telogen hairs. And then that's what's going to happen is you're going to get pluggy hairlines when you think that a single hair graft, you think it's a 1 when it really has a baby next to it. And then you implant it, and then you got a bunch of 2s in the front of your scalp. So that's another reason why you really have to use it. And in FUE cases, it's sort of the similar, sort of that principle. Everything in my office is done using microscopes. You do need to sort the grafts, I believe, with a microscope too, because you need to turn the graft over and you need to really inspect for those telogen hairs. Of course. Yeah. Trim off whatever, if there's a partial transection and you need to trim off a hair shaft, you need to do that. You want to trim the fat cap off, and you don't really want to damage the follicle while you're doing it. There's so many different.
Hold on. I want you to repeat that part about not just sorting.
You do not want to damage the follicle while you're doing that, and while you're trimming off the extra. Everybody's going to have some partial transections. Anybody who says they don't have any partial transections is lying to you. So you don't want to put a graft in there with an extra hair shaft or an extra, I call it a twig without a berry or a berry without a twig. You need to trim that out. And there's no way that you can do that without a microscope without damaging the graft.
And that's boom. Thank you. And that's what I was talking about, where I kind of left that part out of my video because frankly, I didn't think it, I mean, the video was already 20 minutes long, and to add the dissection part, I actually did talk about it a little bit, but I didn't expound on it. But I didn't say sorting, and everyone's taken, what I was talking about, and they say, well, you need microscopes for sorting. And it's like, okay, well, that's like a third grade level of use of microscopes. Sure, sorting so you can see them, but there's so much more to it. And I did talk about dissection refinement. I even showed Steve Gable gave me a really great video clip of slivering a strip into smaller pieces and then the further refinement. But that's something that people aren't getting. And I will be making a video about this at some point. The need for actual dissection of what appear to be follicular units, but you need to dissect that extra tissue away for smaller incisions, less adipose around the follicle itself. So smaller incisions, less trauma, dense packing higher dense packing is possible. But there's also the option of, is that actually a 2-hair graft or is it 2 singles? Well, I think we need some singles for the hairline, so let's make it so. Engage, slice, but you have to have the experience to be able to do that properly. You want to expound upon that a little bit?
Well, 150%. So experience is important when, we have, we're fortunate because the majority of our technicians have been doing this for 10 to 20 years. But whenever we do have a new, which we do have a couple of newer staff members, the one thing that I do not let them do at the beginning is, they don't make single hairs. So I think that's one of the most challenging, important. We all know that the singles are the signature of the modern day transplant. And if those cannot be done correctly, you will have a suboptimal result. Very rarely, if you're doing good extractions, do I believe you're going to get a full 300 to 400 singles out of your case to be able to make your hairline. So in almost every case, I do believe some singles need to be made. I prefer to make singles out of 2s. I feel like, number one, I want my 3s and 4s to get density, so I don't want to traumatize. I don't want to waste those on singles. And number 2, I think it's a lot harder to make a single out of a 3 or 4. Now, if you're a clinic that's trying to tell somebody that you did 300 or 400 grafts, the only way you're going to be able to do that 3,000, 4,000 grafts, you're probably going to have to split some of these 3s and 4s up. And I think that's why a lot of times you're damaging the singles that you're going to end up putting in. So, and it gets really fun when it's white hair too. So I'll just add that in there also.
Right. No, yeah. Throw in the white hair component. And quick side question before I get into a question from the chat. And thanks everyone for your patience. Like I love talking to other professionals in the industry, talking about the nuts and bolts of surgery. It's in my blood. I love it. What in your view, when is a hairline a failure when it comes to the number of doubles that wind up? How many doubles do you think is acceptable? Because it always happens. Like it happens. Like we know this. How many doubles? Well, and this can vary. Do you think is acceptable for a hairline?
Honestly, none. So this is the school that I went to when I started doing this, and still now. Before I would post any before and after photo or send it to Joe or anything, I'd always send it to my father. And I'd say, look at this beautiful work that I would do. And in the beginning, he would literally zoom in on it and he'd pick 1, 2 out and say, this is no good. So to me, yeah, literally. So, and I'm being open with everybody about that, but they say you always play better for a tough coach, right? So the bottom line is, in my opinion, in a patient with very fine hair, you can get away with some 2s in the front. Yep. But once the patient has more coarse hair, all it takes are 2 or 3 of those 2s that are not properly camouflaged by your singles, and I think the whole result is ruined.
Yeah. Yeah.
That's the level, that's the standard. And I've literally shown my technicians photos, where I will zoom in and show them, that 2 or 3, grafts pop through that aren't camouflaged by a single. And, I'm not happy about it. And the patient probably doesn't even see it. So my answer to Joe's question is the majority of the time, none. And in a patient with very fine hair, maybe you can get away with it a little bit.
Yeah. Okay. Fair enough. I like that. I like that answer. That's good. And I can appreciate the dad component. That's good. Okay. So back to the questions from the chat. I do appreciate everyone with your patience on this as I go off on a geek rant with Dr. Nussbaum here. So, okay. So Tyler had asked this question before. I did see it earlier. He'd like to know Dr. Nussbaum's thoughts on creatine intake for working out if you're taking finasteride 1.25 milligram daily.
So there was this old paper, and I've struggled to find it, but I've read it several times, where it gave sort of an anabolic index for a lot of these workout supplements. We obviously know the highest one of them is TRT, or testosterone replacement therapy, but creatine was pretty high on the list. So what I tell patients is there is an anabolic component to creatine. We do now pretty widely understand that it is not great for hair loss. And I also know that a lot of the, like even some of the pre-workouts and some of those sort of stimulants or thermogenics, as they call them, with a lot of those amino acids, I've had patients shed a lot of hair from that. I once was trying to take one of these pre-workouts, and it had L-carnitine in it, I remember.
Oh,
and
yeah.
I mean, I shed like a dog for 2 weeks. Like, I've never seen more hair come out of my head in my life. So in terms of creatine, I think the general consensus among the hair
Dad,
loss
what's going on?
yeah, right? You're taking that protein stuff again. But
Yeah.
anyway, I think it is well accepted that the creatine is not good for hair loss, and it is because it does have sort of an anabolic index or anabolic
Okay.
potential. So I usually tell patients to stay away from it.
That's a great
Not
answer.
as bad as testosterone, but I don't like it.
Okay, fair enough. I appreciate that one. That's a really good answer. If you can find that paper, I'd love to get a copy of it.
Yes.
Yeah, because that'd be fantastic. Let's see, next question here is pop this up again. Tyler says, "Thanks, Doc." That's awfully nice. All right. Yeah, XYZ. That's original. Question: if you have slightly curly hair, does the doctor need to place each hair in the correct rotation to lay correctly once healed and growing? Good question.
So I think the grafts need to be placed in the right direction, regardless whether you have curly hair or not. So every hair follicle has a slight curl to it. So there's only one direction that actually is correct. So you always want the curl, I guess, facing down. So whether it's a person with truly coarse, type 3 or 4C type of hair, or whether there's always a little bit of a bow to the graft.
Yeah, a little bit of
you don't want this. You always want this.
Yeah.
And obviously, depending on the orientation of the angle. So I don't think that it is as, I guess what I would sort of say is I think it's important in all the cases that the grafts are positioned properly in orientation angles, but certainly in curly hair. The funny thing about curly hair is usually once it all grows in, it all sort of curls up and bunches up. So I don't even know if maybe you could make the argument that it's less important in curly hair. I'm not going to go there and say that, but I do think it's a crucial part of the placing process. I think that's another I'm going on a tangent, but it's another complaint I have on implanters. Which I do not use, and my staff is very, well trained in using forceps. But that's one of the other things that I think is important, is that they can really see the angle and the curvature of the follicle and the curl to place it in the correct direction. Whereas if it's put in an implanter pen, I do believe that becomes more challenging when you're loading those into the devices.
Okay, all right. And now we're talking about curly hair, but let's talk about. You're talking about grade. Sorry, what's the scale for curly hair again?
Like 3 or 4C. There's a couple of them.
Yeah.
But,
okay. So the more extreme tight curls, like a 4, does it really make a difference for the angle or the direction of placement?
I think it's the same. I think this is a caveat to that. I think and this is more for probably surgeons who are trying to do transplants, but I think the site has to match the graft. So when I'm making sites for coarse, curly, or African American hair, I am not making a straight slit. how are you going to put a curl into a straight hole? I
Well, of
actually
course.
do a little bit of a rotation, and I think my team appreciates that tremendously in being able to place the hair. So I don't have a right answer whether it's important or not. I think if it's a crown and it's curly hair, it probably doesn't matter as much because it's all going to bush up and curl and it's going to be fine. But I think in your hairline or the front, I think the orientation of the graft is important regardless of the curl or not.
Fair enough. Yeah, fair enough. That's a great answer. Let's see, another question. Guys, keep the questions coming. Here's a good one from Amarafi. I have strong retrograde along with some diffuse thinning on top. Is it worth to address my retrograde with a hair transplant?
Well, if you have retrograde alopecia, you may or may not, but mostly you probably have a component of DUPA, which only can be made under, without looking at a dermatoscope. You can't make somebody a diagnosis of that. But generally, if you have, the simple answer is if you have retrograde alopecia, you're usually not a candidate for a hair transplant.
Good answer. 1 second. Okay. Let's see. All
now,
right.
I'll say one other thing. People
Okay.
with DUPA and retrograde alopecia do usually respond exceptionally well to medical therapy.
Okay. Yeah, I agree with that, actually. Yeah, diffuse thinners, retrograde, I've seen a lot of really spectacular turnarounds.
Same.
Particularly when you've got, like, say, conditions where it's like a 5A diffuse pattern, but you can just make out that outline. It's not to the point where people will be like, man, that guy's bald, but it's halfway in between, I guess you could say, but they're still retaining that hairline. Those, in my opinion, you see one of those, get them on medication, boom. That's the biggest turnaround you're going to see on that kind of patient right there. I love seeing those patients, and I love seeing those results with finasteride. That's usually, in my opinion, the ones I've observed more commonly. Next question is, okay, this is a good one. It's a very, very simple one, but I'd love to hear your answer for Neil. How exactly do hair transplant surgeons know which angles to use for implanting? Is it some machine learning software?
You mean in terms of recipient site creation?
Yeah,
How to make the
I'm
angles,
assuming
correct?
that's what he means. Yeah.
Yeah. So what I will share with everybody is even in a type 6 or a type 7 or somebody whose hairline is totally back, when you put your magnification lenses on, you will see the baby fine vellus hairs are still there. And you can make out the direction of those. So even in a bald guy, he will have some remnants of vellus hair, and that is the direction and angle that you're going to follow.
Yeah. It's very rare, in my opinion. Like, there are some situations where it can be argued that taking your own direction and angle to compensate for, say, a lack of numbers with the procedure, donor was a supply versus demand shortcoming, where you can compensate in ways that Mother Nature didn't intend with the original amount of hair, like, say, flatter angles for better coverage of,
Right.
Coronal angle incisions, spreading the grafts out with a little slit right down the middle of that foregraft to make it fan out for better coverage, little tricks like that. But it's something where I think it's a great question. Like, if someone doesn't know anything about hair transplant and they keep hearing, well, how do they match angle and direction? What are they doing? Well, they're using magnification, and they're looking very closely to see just where that direction takes the flow. Because when you look at the growth on anyone's head, there's a flow, there's a pattern that radiates from the central whorl pattern of the crown, and it radiates outward. Usually it's clockwise. The occasional patient will be counterclockwise, and then even more rarely you'll have a double whorl, which is crazy. But it's following that flow for direction, and then your angle from the exit of the scalp, or from the plane of the scalp, is determined by looking at the profile of the other native hairs in that region. So it's a great question. I love questions like that, because when you get down to the nuts and bolts of a hair transplant and a proper approach, that's how you get naturalness. combined with other things that Dr. Nussbaum was talking about, where we're talking about dissecting grafts, not just sorting them using microscopes, transection rates, things like that. All of this accumulates with experience, obviously, behind you into the highest probability of a natural result, which is what everyone should be looking for, and understand what that is if that's what they're looking for. Does that make sense? Doc, did that make sense? Did that come out okay?
I'm with you.
You're with me. Okay, good stuff.
I agree. And it's the hardest. It was one of the most challenging things when I started doing this to learn and follow. And now that I'm training some other doctors and fellows to do this, I think the direction is something that it just takes time, and it's the artistic component to it, but it is one of the most challenging things for people to catch on.
Right. Yeah. Yeah. Agreed. 100%. So 4:53, we're coming up to the end of the broadcast. We'll get a couple more questions in. And just so you guys know, sorry, hold on. Doc, you're saying something? What were you saying?
I wasn't saying anything.
Oh, sorry. I thought I saw your lips moving. That was, okay. Delay on the YouTube there. So just so you know, I've not taken any more phone calls simply because the input that I have, it's a technical issue on my end. I didn't compensate for Dr. Nussbaum calling in and the phones being available as well. So there was an echo. So if someone calls in, I can't put you through because I don't want there to be a bad echo. So apologies about that. Hopefully we'll have it fixed for tomorrow's show. But let's get back to the questions here. Okay. Milk Drinker has a good question here. Is there a difference between a double where both hairs leave the same hole or exit point and one where the hairs exist in two different exit points, and if so, can the latter be used for a hairline as if they're two singles? That's a very good question. Do you understand, Doc?
No. Hit me again.
Okay,
wait a minute. Okay.
So he's asking a double hair graft where both hair shafts are exiting from the same exit point versus a two hair graft where they're side by side. Can a side by side two hair graft follicle be planted and be passed off as two singles?
You would have to split them.
Yeah. I know the answers. I don't want to put words in his mouth because I want the doc to answer this. But
right.
Yeah.
So you would have to split that one, and it's like there's this subjective. Unfortunately, more so with strip surgery, you're relying on your technicians to sort of decide. Sometimes, do they keep those two singles together to make a two, or do they split it up into two ones? And that's kind of a judgment call on the people that are working under the microscopes. I think it happens less so with FUE because the punches are so small now that I think you're really getting that intact follicular unit. But you would want to, in that case, if there is a little bit of interfollicular distance and you do need single hairs, that would be a good one to split into two.
Yeah, exactly. Yeah, well said. Great question. That's Milk Drinker has some good questions. Like he's been a subscriber to the channel for a while, and I always appreciate his comments after videos are posted and during live chat. So thanks again, Milk Drinker. Got milk? Just kidding. Had to ask. Al Franny asks, what are your thoughts, Dr. Nussbaum, on natural remedies to treat hair loss? For example, rosemary oil. And he says, ha ha.
How did I know that's what he was going to say? I personally, I have not seen much success with them in my limited experience. I do think that there is some, in my limited experience using them. I am not saying, that it may not help, but I sort of am somebody that, as a medical doctor, not a holistic doctor, an alternative medicine doctor, I always go to where's the data. And until I see, randomized controlled trials with many, many patients and systematic reviews and things being used for a long time, I don't feel comfortable telling people to do things. I do think in terms of natural therapies, there are some vitamin supplementations that maybe will help for female hair loss and telogen effluvium and things like that. But in terms of treating androgenetic alopecia, I'm not really sure that I completely buy, that natural remedies really are going to reverse it. And it's similar to the saw palmetto talk. I don't know how natural we would consider that or not, but, I think the amount of saw palmetto that you will need to actually suppress DHT is probably a whole field of saw palmetto.
Yes. Yeah, exactly. what's funny is like I tell people, what they say, well, I want to go natural, so I'm going to use saw palmetto. It's like, well, what's the difference? Because it's the process of reducing DHT formation that's causing the side effect. So if you take enough saw palmetto to actually make a difference, if you're going to have side effects on Propecia, you'll probably have side effects on saw palmetto. Just saying. So, by the way, when I was a kid growing up in Florida, in Central Florida, my grandfather used to take me out and he showed me how to actually harvest saw palmetto. It's tasty. You ever done that?
I have not. You'll have to show me one day.
The little baby palms.
Okay.
What else we got here? Okay, so another question here. We're wrapping this up. Final question from Sergey. Always good questions from Sergey. Did Dr. Nusbaum have cases where patients did not respond well, in parentheses genetically, to dense packing, okay, and needed a touch-up with lower density later to fix it? Does that make sense?
This is a tough question because I've never, in my own experience, from a patient who has come to me for their initial procedure, I have never had a situation that I can think of where I felt like I had poor growth because I overly packed grafts. I don't, and maybe that's because of what my dense packing is not what some other people's version of dense packing is, because once again, I am not quantifying that truly, but I have not had that case in my sort of, from my patients originally. Do I have people, and then the question becomes, they were dense packed, they got 4,000 grafts, it didn't grow. There's so many other factors that can go wrong, or that could have gone wrong, that how do you know? There's no way for you to know, for a patient that comes to you with a suboptimal result, what exactly went wrong. In terms of growth. I mean, not when we're talking about naturalness, but in terms of poor growth, there's no way for you to know, did the grafts desiccate? Did they manipulate them too much when they were trimming them? Did they warm up? Did they manipulate them when they were planting them? There's no way to know if it was dense packing. The only, I guess, caveat to sort of this is, I can think of one patient who, in scar tissue had, he had a big flap from like an injury that he had, and he had a doctor do sort of a real full definitive transplant that didn't really grow well. And I went back there and I did kind of test sites first at a lot lower density, and I was able to get the grafts to grow better. So that would be the only instance that I can think of, sort of in a post-traumatic scar, which isn't truly, I don't think, of what you were quite talking about. But there's no way to really know, was it the dense packing that caused them to have poor growth or not.
Growth where you're thinking, yeah, it could have been better, and you go back and you see that they were a bleeder, where you determined that there must have been a lot of you're talking about manipulation of grafts, so there must have been a lot of manipulation of grafts to get those grafts
popping,
back.
Things like
Yeah.
that.
Yeah.
Right.
Popping. And so, constant, it's like, damn, it keeps popping and keeps sliding back in.
I call it whack-a-mole. You put one in and the other one, it's like this constant.
Yeah. The whack-a-mole effect. Yeah. So that's probably one of the few situations, I think, where you could actually look back on the chart and say, yeah, okay, so maybe some manipulation was a little more than it should have been because of the bleeding factor. And then it's like, okay, why was he a bleeder? Was he a smoker, or did he use minoxidil, any aspirin 2 weeks before, things like that, the basic questions. So yeah, okay, well, that's great. And, I got to tell you, Doc, it's been a real pleasure having you on the inaugural broadcast of the main event. And you're great on camera. Really appreciate your knowledge and your participation. Any thoughts or words of wisdom you'd like to provide for the audience?
Well, first of all, Joe, thank you. It's always great to talk to you. You know how much I always enjoy speaking to you, and it's honored to be able to, even on short notice, being able to work it out so that I could be here with Joe and everybody else today. What I would say, my pieces of advice is, the people who are listening and who are on this show, I think you're doing the right thing. And because you're listening to people like Joe, and you're educating yourselves on what, the do's and don'ts, the good, the bad, the pitfalls, the success stories, all of it. What I would, wish and hope is that you can help people like Joe and doctors like myself and all of us who are part of these groups and associations like the IAHRS and Spencer Coburn. You guys are all doing the right things by tuning into these shows and trying to educate yourselves and properly educate yourselves on all this crazy field of hair transplants. And I don't know how, but it would be great if you could help us disseminate this information to the millions of people that are out there that don't even know that these sort of platforms exist. So that would be sort of my call to action is help us, you guys are doing great, but help us continuing to help the people who may be unfortunately falling into the wrong hands and not properly educating themselves before undergoing these things.
Wow. That's well said. Thank you for the plug there. Pardon the pun. That's good. All right. Everyone, thank you for joining us, and thank you for your questions. Tune in tomorrow, 3 p.m. Pacific time, 6 p.m. Eastern time for the main event. I don't know who the guest will be, if I even have a guest, but I will be here. Be sure to check it out, and I hope to have if I have a guest, then I hope the phone system will also work out to where it's not a big echo. I do apologize about that. I'm learning. Cut me a break. Thanks, guys, for joining us. Bye-bye. And hold on.